So it is my pleasure to introduce Dr. Robert Teasel. Dr. Teasel is professor at the Schulich School of Medicine and Dentistry at Western University. He's the former chair chief and the current research director of the Department of Physical Medicine and Rehabilitation. He is a clinical researcher with Lawson Health Research Institute at the Parkwood Institute Research and director of the CORE Research Group. He has authored more than 370 peer-reviewed articles and been involved in over $27 million worth of grants. He has won many awards, including being the Natasha Lecturer at the 2016 World Stroke Congress. He has the 2018 Lawson Impact Awards, Scientist of the Year, 2018 Post-Acute Stroke Excellence Award, the American Congress of Rehabilitation Medicine and National Stroke Association Award, and the 2019 Glenn E. Gresham Visiting Professorship and Lectureship in Rehab Science in Buffalo. His research interests include evidence-based practice and complex analysis of the evidence in neurorehabilitation. It is my pleasure to turn the mic over to Bob Teasel. Bob?
Thanks, Eileen. I'm going to try and share my slides here. And there we go. Okay, well, thanks for inviting me. As you know, I came and spoke last time, and in that discussion, we talked a bit about standardized care and then the use of adjunct therapy and how these things are starting to fit together. What I'm going to do today is just do a bit more of a nuanced talk on this, things that I think you'll find will be very practical, focusing a bit more back onto the intensity and then how adjunct therapies fit into a model of care and some of the new data coming out of Ontario with regard to how much therapy we really need to be providing to get maximum impact. And I think you're going to find that part really, really interesting. So let's move on. And this is a slide that I showed you previously. And this is something that we've been working on for the last 20 years, the idea of standardizing care. And standardized care really focuses on key principles for which there's widespread agreement among clinicians, policymakers, and administrators. It's not often you get that we need to be providing stroke rehab units, intensive care, early access to therapy, task-specific therapy, and then access to community-based. Really going to focus on 2 and 3 today, and then talk about what those things really mean and some of the old data that's out there that we need to understand how these two interact, and then some of the emerging data that's going to, I think, in the end, change how we see how we practice versus what we currently are expected to do. All right. So intensity matters. And then if you get anything else from this talk, that's what I'm going to really drive home. Nearly 2/3 of stroke rehab research is on interventions designed to improve motor recovery. That makes stroke quite unique. It's got well over 3,500 RCTs now looking at just upper and lower motor recovery. So I'm going to focus on that because that's where the huge amount of data is. Another 600 on cognitive rehab. Not going to quite spend as much time on that today because I think that the other one illustrates the principles I want to talk about a little better because there's so much data. We do know that repetitive task-specific therapy for physical therapy interventions has been shown to have strong evidence in improving stroke recovery in all phases of stroke. The same in speech therapy, and we were the first to show that with our paper by Sona Bugle back in 2003 in stroke, showing that more intensive speech therapy resulted in much better outcomes. And so we know that therapies delivered in a more intensive manner, and this means more hours, greater frequency, result in significantly improved functional outcomes and reduced length of stay when compared to less intense therapies. And the term intensity of therapy has been defined different ways. One is time spent in therapy, the one that you're most familiar with. Another one, though, is augmented therapy time, and we'll talk about that because there's a lot to learn from that in terms of when therapy is applied. And then something that's really important to actually the mechanics of thing is the number of repetitions. We won't spend quite so much time there. So I'm going to start off with dealing with that. And time spent in therapy is probably the way we most commonly measure intensity of therapy. It's certainly how we measure it in Ontario, as you know, and it reflects the amount of therapy time received in observational studies, and meta-analysis have revealed that time spent in therapy is a very strong predictor of overall functional improvement. And I'm going to show you a paper by Lowell Cowra. It's a bit old now, it's 20 years old, but it's out of England. But it's probably one of the most elegant studies I've shown that shows that it's not just the time spent in therapy, but the intensity of that therapy that's important. And so what he did was he did a randomized controlled trial of 146, what they used to call middle band or moderately severe stroke patients, to a stroke unit or to a general medical unit. And the patients had a median Barthel index, and the Barthel index is just a score of ADLs of 4 to 20 initially. And those of patients that were admitted to the stroke rehab unit had a Barthel index score of 15 after 6 weeks and were discharged at 6 weeks. And those patients that were admitted to the general medical unit had a Barthel index of 12 after 12 weeks and were discharged at 20 weeks. So dramatic differences between being admitted to a stroke unit or being admitted to a general medical unit in terms of your ADL improvements and in terms of the time you're discharged from rehab. And this just shows you the mean Barthel score for the stroke rehab units. Can you see my pointer?
Yes, we can see it, Bob.
Yeah.
Okay. And then the general medical unit here. And here's the time to discharge. And you can see quite dramatically quicker in the stroke rehab unit than on the general medical unit. The reason I show this, though, which makes it really interesting, is this is the amount of rehabilitation they got for both physiotherapy and occupational therapy. And this just shows you in the stroke rehab unit the amount of physio and OT they got. And this just shows you in the general medical unit the amount of physio and OT they got. And you can see that in the general medical unit, they actually got a bit more therapy than they did in the stroke rehab unit, yet the stroke rehab unit had dramatically different results. And the reason for that is that the therapy that was delivered by the stroke rehab unit was delivered within 6 weeks, and the same amount of therapy delivered within the general medical unit was delivered within 20 weeks. And just the fact that they received the same amount of therapy in a much more intense manner, resulted in dramatic improvements in terms of their ADL scores and dramatic improvements in terms of the time they were able to be discharged from hospital. And I love showing this slide because it so dramatically shows the effective intensity in rehabilitation. And so this has been a concern in Canada. As you know, the Office of the Auditor General of Ontario in December of 2021 released a report that said, rehab's really not meeting best practice recommendations. Guidelines that we currently have that are based largely on American data recommend 180 minutes of physio, OT, and speech language pathology. And in the United States, 3 hours of therapy is the standard. And it does have a better prognosis when compared to less than 3 hours. In Ontario, the median amount of therapy in inpatient rehab has increased from 57 minutes to 69 minutes per day, but is still well below anticipated targets. And in this study by the Auditor General in stroke rehab inpatient units serving 40 or more patients that year, therapy varied from 22 to 110 minutes of therapy per day. So we're not quite making that guideline, and it just seems like it's almost unobtainable. So this whole idea of 180 minutes, though, is now starting to be turned on its head. This is, I think, information that is just now appearing. It's just appeared in the International Journal of Stroke. It's still in press, but you can get it at the journal's website. This is a Canadian Ontario study done by Shannon McDonald out of Toronto. Jamie Fleet, who many of you know, who's here now in London, but was a resident in Hamilton. Mark Bailey, who everybody knows. And it was a study from the ISIS data set that looked at 12,770 individuals admitted to inpatient rehabilitation facilities in Ontario, Canada from January 2017 to December 2021. Mean age was 72 years, 46% were females, pretty standard group of patients, similar to what you would have on your unit. The mean rehab intensity that patients got was 74.7 minutes. The range across the 12,000 patients was from 5 minutes to 162 minutes. Not a single one of the patients that was of the 12,000 received the full 180 minutes of direct therapy from PT, OT, and speech therapy. And the rehab intensity measured the total therapy minutes divided by the length of stay. However, what they found was really interesting, because what they found was, and you can see from this diagram, this just shows you the FIM change, and this just shows you the amount of therapy they were getting at the bottom. And the bottom line here, and the important thing with this study, I'm going to go through it quite a bit because it's really critical to how we think about rehab, is there was this key point at 95 minutes. And it seemed that patients improved in their FIM scores up to 95 minutes of therapy a day. And after that, it really diminishing returns. It really started to fall off. And so the increased rehab intensity was associated with an increase in mean FIM scores. So that was really critical to get as much therapy as you could get up until the 95 minutes. And then it starts to taper off. So it was this diminishing incremental increase at over 95 minutes per day. And as you can imagine, that starts to have some interesting implications for how we manage our patients. And I'm going to go through some of the other data they found. Fascinating study, actually. This just shows the motor FIM. The motor FIM is the 13 items, motor items of FIM, and the cognitive scores, which is the 5 cognitive measures of FIM. And you can see for the motor FIM scores, after 95 minutes, which is right here, really a marked diminishing returns. For cognitive FIM, you see a little more of a straight line. You continue to get gains with access to more than 95 minutes. And this is probably an impact of those patients that are aphasic that need continuing speech language pathology treatment that pushes it above that 95 minutes, more so than patients that would not require that. Here's the odds ratio that the patient will be sent back to their pre-admission setting. Now, this is really, really important. The likelihood that that patient's going to be able to go back home or from which they came, that is the odds ratio that is directly related to how much therapy they get till you get to about 95 minutes. So if you're getting a patient only 50 minutes of therapy, they're less likely to go home. That's a big deal. But if you can get up to that 95 minutes, any additional therapy after that has much less of an impact on whether that patient's likely going to be able to go back home or not. And this is 95 minutes, 7 days a week. And this just shows you the odds ratio of discharging a patient to long-term care. If they're not getting much therapy, they're more likely going to go to a nursing home. Once you get to that 95 minutes, they continue to improve, but it begins to taper off to some degree. And so what they found in conclusion was that none of the 12,770 patients met the recommended rehab intensity of 180 minutes per day. This is over 4 years. This is in the Ontario at the end of a long time of us preaching and having guidelines that say you need to do 180 minutes. I think we can pretty safely assume that isn't going to happen. And maybe we need to start rethinking this thing. Higher rehab intensity, though, is associated with better outcomes. You can't get past that. That's really important. But after over 95 minutes of rehab intensity per day, there is a diminishing returns for total FIM, motor FIM, rehab effectiveness, and 90-day home time. Now, it's interesting, in their study, 3,000 patients, or 1/4 of the patients in Ontario, actually had achieved a rehab intensity of more than 95 minutes. And so we're beginning to think that maybe we need to rethink what we're doing and not set targets for ourselves that we'll never meet, but rather try to make sure that everybody at least achieves the 95 minutes per day, 7 days a week, which is much more feasible as our minimal therapy, rather than trying to do the unachievable 180 minutes per day and in the end really not accomplishing anything. And just to let you know, aphasic patients may require more because the speech therapist is more engaged. And that hasn't been fully studied yet. All right, so that's probably what I think you'll find the most fascinating for those of you who are paid attention to what's been going on, is that we might be re-looking at a reformulation of how rehab is practiced, but with that will come greater accountability to ensure that people at least reach the 95 minutes if we're going to rely on best evidence to tell us what to do. All right. So the other way we can measure intensity, and there's some real value in looking at it this way because it does illustrate some key concepts, is that increased therapy has been described in terms of the number of hours that a therapist provides, but it's also been used, particularly in randomized controlled trials, as augmented therapy time, where, you know, it's easy to do. You just add an extra few hours of therapy, and then you assess whether that makes a difference over patients that did not get the augmented therapy. And Van Peppen, at least for in the acute subacute phase and for motor recovery, has noted that additional therapy time of about 17 hours or 20 hours over 10 weeks is necessary to see significant positive effects. And this has been affirmed by Verbeek. Both of them are Dutch, by the way. And Dromerick actually, and I showed this at the last talk I gave, Dromerick unfortunately died during COVID, but a great neurologist, did this paper, which was published just after his death, on the critical period after stroke study, the CPAS study, where he said, we're going to try 20 hours of extra hours of self-selected task-specific motor therapy to patients. We're going to try it at the acute phase, and then we're going to try it at the subacute phase and at the chronic phase, and then we're going to compare them to each other as well as a control group that just received standard motor rehab. And they use the ARAT, which is the action. Anyways, it's the well-known measure of upper extremity function that has some impairment scores built into it. But they did this measure of upper extremity function, the ARAT, and they found significant and greatest differences in the subacute phase and the acute phase, but not much improvement in the chronic phase post-stroke. So 20 hours of augmented therapy was enough in the acute and subacute phase to produce a difference, but not enough to produce a difference in the chronic phase post-stroke. And so that's an important finding, I think. So we know that 20 hours of therapy in acute subacute rehab can improve recovery and or functional outcomes, but not in the chronic phase. Sorry, I got the fire alarm warning here that they give every day on. Anyways, and so the 20 extra hours of therapy in the acute rehab and acute subacute phase, but doesn't appear to be the case in the chronic phase. And in fact, this was shown with the eye care study that Dr. Weinstein, a well-known large multi-site RCT, compared patients who received 30 hours of a structured task-specific upper extremity program over 10 weeks in an outpatient setting, and showed no significant difference in outcomes when compared to those receiving usual care. And there was a big study, and people were quite devastated by this. In fact, argued that until they started really looking at the timing, that those 30 hours had made a difference. Lang in St. Louis conducted a similar study and found that 32 hours of therapy in the chronic phase did not improve upper extremity function. So what does improve upper extremity function in the chronic phase? Well, McCabe did a study, and he found that chronic stroke patients who got 300 hours of activity-based therapy in the chronic phase did show a substantial improvement of upper extremity Fugl-Meyer above the minimally clinical important difference. So you can affect change in the chronic phase, and he showed you can, but it took 3 hours of therapy. Ward, in a well-known study out of London, England, it's a retrospective review of 224 patients who were a median of 18 months post-stroke, treated with a high-intensity rehab program of 90 hours of therapy overall, found that it did show a significant improvement in the ARAT and the Fugl-Meyer scores. So what you can say is, and Kramer really summarized this nicely, he says, in referring to therapy in the chronic phase, these positive results will forever change how research into activity-based training after stroke is dosed. 90 hours of therapy improves arm function, while 32 hours of therapy does not. And so we have good evidence, and this is really my key point, is that augmented therapy of 20 hours in the acute and subacute phase is equal to 90 to 300 hours in the chronic phase. And it just shows you how important additional therapy or therapy is in that acute and subacute phase. If patients have to wait for rehab, the patients are delegated to more outpatients where they're going to get all of their therapy, it's not going to be the same. The resource is best spent in the acute and subacute phase if you're going to get the biggest bang for your buck. And I think we all kind of know that, but the evidence for it is really quite spectacular. Literally, it takes 5 times as much therapy in the chronic phase to produce the same kind of impact that you're going to see in the acute and subacute phase when compared to similar control groups. And so the brain is clearly primed to recover early in the post-stroke period. And animal studies suggest there's a time window when the brain is primed for maximal recovery to rehab therapies, such that delays in therapy are detrimental to recovery. And we have pretty good clinical associations between early admission to rehab and better functional outcomes. But the point I really wanted to make here is that 20 hours of therapy in the acute and subacute phase is equal to 5 times as much therapy in the chronic phase. Let that sink in, just how important it is to ensure maximum intensity of therapy in the acute and subacute phase. And then the final way that we can measure intensity is through repetition. And repetitive task training involves active motor sequences performed repetitively within a single training session aimed towards a functional goal. And the Scots, who do a lot of these reviews, have upper extremity stroke rehab found that adequately powered high-quality RCTs confirm the benefit of a high dose of repetitive task practice. Repetitions of number of repetitions during locomotor training has also been used to represent intensity. And when doing sit to stand or upper extremity function, increase in repetitions during rehab is effective in improving functional recovery, and that's been well proven. No study, though, has systematically determined a critical threshold for rehab intensity needed to obtain a benefit, but the research suggests that you need about 200 to 300 to 400 repetitions to form a new motor engram. So to develop new motor patterns, which is part of recovery, you have to do between 100 to 400 repetitions. Lang, when she did her study of occupation, she just observed occupational therapists providing upper extremity rehab sessions in the United States. And she found that therapists did repetitive upper extremity activities about half of the sessions. And on each session, the average number of repetitions was only 32 per session. So a lot of work we need to do in order to try and improve the number of repetitions people do as part of that rehab intensity. It's just not a matter of how many hours we spend with patients or how much augmented therapy get, that the quality of it as well with regard to repetitions is also important. Now, this is an interesting area that we've been studying, and one of my nurses suggested it as a rehab topic that we ended up running with, that, we talk a lot about rehab therapies. We don't really talk a lot about the role of rehab assistance because it's not measured in terms of direct therapy, and we certainly don't talk a lot about nurse contributions to stroke rehab. And part of the reason is that nurse contributions to stroke rehab have always been viewed as pivotal, but they're therapeutically nonspecific, and that's part of the challenge. It's not as clearly defined as it is for PTs and OTs, and hence often not measured and often not recognized as being important contribution. A paper worth reading is Tan Laka's paper. He's out of Windsor, where he conducted a review of 7 articles examining the role and contributions of nursing in stroke rehab units. I've listed the reference down below. He covers a number of themes. I'm only going to cover one that I think is important, and that's the whole concept of activities of daily living. And this was a constant theme in all of the 7 studies that he looked at. Nurses spend 24 hours a day, 7 days a week with patients, providing basic care. Nurses account for 60% of the budget on a stroke rehab unit. So they're really critical to how well the unit works. To maximize a patient's independence in ADLs, the nurse initiates the activity. They then coach and encourage the patient to perform it independently until the patient can perform the activity without assistance. The nurses also help the patients to use the skills they learn from physiotherapy and occupational therapy to perform their ADLs. And this constant practice of rehab interventions enables the patients post-stroke to practice and integrate those tasks with their activities of daily living. And rehab assistants provide a similar but therapeutic specific role. So this is something that really is, I think, to some degree underestimated. I'll tell you a story that I think is something unfortunately quite tragic in my own family that really drove this point home to me. But one of my younger brothers had a stroke about 2 years ago, quite a large stroke. And it was the right hemisphere, but he's a left-hander, so he also developed some language problems as well. And it was around the time of COVID. He was in a large center, but not Vancouver, in British Columbia. He took 5 weeks before he got into rehab. He was a previously healthy 65-year-old gentleman. And then once he got into rehab, they had trouble providing a appropriate intensity of care, although I think that was not one of the major issues. But because they were having trouble staffing their unit with nurses, the nurses could not practice. They had to use equipment because they weren't skilled enough. The nurses weren't able to practice his transfers at all. So even though he would practice transfers with the physiotherapist, the nurse weren't able to continue with it. And so, unfortunately, with that combination, he ended up did not make a particularly good recovery and ended up going to a nursing home. And I can't help feel that if he had have gotten more intensive therapy early on with a team that was able to then practice what was happening on the floor, that the result might not have been different. And so, it was an unfortunate situation, unfortunate series of events. Still continues to be an unfortunate situation because he's still in a nursing home. But it really drives home to me how important these factors are. The things we often don't think about, and I often didn't think about it till I actually had to experience it in a situation where that wasn't available like we would typically expect it to be available in Ontario. So that's kind of an example of illustration of why some of these points are, at least from a personal standpoint, very important. All right, so I'm going to talk about adjunct therapies. We talked about them before. I'm going to show you some data that we've not yet published, but I think is really important. Shows you that adjunct therapies are important, but applying them early on is also important. So they also are very, very susceptible to time post-stroke in terms of their impact. And this is a forest plot. I'll explain it, but go through it with you. But these are the various treatments. And what we did is we took all treatments that used the Fugl-Meyer as an outcome measure. Now, Fugl-Meyer is like a Brunstrom recovery stage. It measures motor recovery. It's an impairment scale. We also confined it to RCTs that had a similar control group, so we could compare the different treatments. And the control group was conventional care, so whatever they would have gotten regardless. We then looked at the number of RCTs, looked at the number of participants, combined the RCTs and came up with an efficacy score, and looked at, this is the most important number, the mean difference in terms of how the Fugl-Meyer changed. And you can see that looking at all of the RCTs for modified constraint and induced movement therapy that met the criteria, we had 12 RCTs. And we were able to show that 12 randomized controlled trials compared to conventional care changed the Fugl-Meyer score by a massive 8 points, which is really quite high because the minimally clinical important difference is around 4.5 to 5. And we showed that functional electrical stimulation made a difference, 6.91. Motor imagery was able to move the needles 6 points. Bilateral arm testing, able to move at 5.66 points. So you can see all of how we did that. So if this line here crosses this 0 line, that means it's not significant. So everything on this side of the line is significant. And you can see some of them numbers were really quite high for minimally clinical important difference. And this was all randomized controlled trials for these interventions. All right. This just shows you when we looked at only those interventions applied in the first month after the stroke, or started the first month after the stroke. You can see the numbers are quite a bit smaller. The number of participants is quite a bit smaller. So the variability is going to be larger, but you can see for modified constraint-induced movement therapy, if you applied in that first month of therapy, you actually move the needle 14 points on the Fugl-Meyer, which is almost spectacular. And for the bilateral arm training, 11.5 points. And for FES, 10 points. For, get that, it's one of the stimulations, 7.6865 points, etc. When you look at 0 to 3 months, where you start to get more numbers, and you're still in that acute subacute phase, it wasn't quite as impressive, but still almost 12 points on the modified constraint movement therapy. And you can see there were a number of treatments that significantly improved move the needle compared to conventional care on the Fugl-Meyer in the 0 to 3 month period of time. When you went to those treatments, and they were actually where half of the RCTs were in the chronic phase, you notice that they don't move the needle to the same degree. And the ones that did were a bit unusual. Motor imagery, mirror therapy, virtual reality seemed to have more of an impact in the chronic phase, but you didn't see the same degree of changes that you saw in the acute and subacute phase. And I've kind of summarized it all for you here. This is 0 to 3 months, and this is over 6 months. And I've listed them down below here, the different types of treatment. And you can see for the modified constraint induced movement therapy, if the therapy was applied less than 3 months, you got a Fugl-Meyer change of 11.9 points. If it was over 6 months, you got a Fugl-Meyer change of only 3 points. Bilateral arm treatment, 11.4 treatment points for less than 3 months, and 1.93 for more than 6 months. Functional electrical stim, 10.5 points if applied in the acute subacute phase, only 2-point change on the Fugl-Meyer if it was applied more than 6 months when compared to conventional care, and so on. And so that kind of illustrated to us that the adjunct therapies really have also are very time sensitive in terms of they have their biggest impact when they're applied early on during that period of neuroplasticity in most cases. All right. So keep that in mind. I'm going to show you this piece of data as well. This is a survey of rehab therapists across Canada. I say in Ontario, but it was actually across Canada that we did. It's a national survey. It's now been published of OTs, PTs, and speech language pathologists across Canada, 400 of them. The purpose of the study was to explore the use and non-use of evidence-based stroke rehab interventions across various stroke rehab settings in Canada. And the greatest use of the interventions were those applied to the body peripherally without a technological component. So it seems that things like things like mirror therapy and constraint-induced movement therapy were the things that were used most often, but things that had a technological component weren't applied as often. Interestingly, we found that few individuals were aware of interventions applied to the brain, either priming or stimulating, that had a technological component, and they were rarely, if ever, used. The exception to this, and this is why I showed this slide, is that therapists with more knowledge of evidence-based interventions, so the more senior therapists, use them more often in clinical practice. And the area where they tended to be used the most was in specialized outpatient rehab settings. So adjunct type therapies, particularly if they had a technological component, were just not used that much in acute and subacute. We're not used that much in hospital areas or in community hospitals, but were used a lot in specialized outpatient rehab settings. And I'm going to explain to you why that probably makes some sense and how we can use that to begin to develop to better introduce adjunct therapy into a model of care. So I'm going to finish off by just showing you, based on all the stuff that you've just seen, some of my thoughts about developing a modified model of stroke rehab, very similar to the model we have, but taking into account some of the things that you've already heard. So we know that intensity matters and the impact is dramatically greater in the early phase, much less so in the chronic phase due to neuroplasticity, which is greatest in the early phase. And so this is the kind of neurological recovery that we do see with our stroke patients. They have their stroke, they're brought to a low level. This would be for the motor side. For the cognitive side, it would be a little more of a longer line. But you can see patients make this very rapid recovery in the early phase. And then as time goes on, you get past 2 to 3 months, it begins to plateau out. And so you can see that they get this motor function, sort of, again, that biological curve where there's a lot of recovery early on, and then it plateaus out as time goes by. And that's in keeping with neuroplasticity, which peaks sort of in that first month and then begins to decline. And after several months, that plasticity has really significantly reduced. And so I've drawn that here for my model. You can see you get the most rapid recovery early on, and the neuroplasticity tends to peak at that first month and then drops off fairly substantially over the next 3 to 4 months. And so my argument is, in the in-hospital stay, what we really need to be doing is focusing on intensive therapy more than 95 minutes a day in that early phase. I think that intensity is so important, it needs to be the focus. That's where we need to put all of our attention, do whatever we can to try and increase that intensity in that early phase. Whoops. And so rehab, we know that rehab therapies are affected by time and intensity and likely related to plasticity. So rehab in a hospital phase needs to be intensity. I don't think there's any other factor that's likely going to match that impact. And you've seen the difference that therapy plays if you apply it in the early phases versus the later phases. It's quite dramatic. So we need to ensure that one reaches at least 95 minutes of direct therapy per day. Now, that intensity can be supplemented by adjunct therapy, but my big concern is I've given it a lot of thought, and we've tried to apply adjunct therapy to inpatient units, is sometimes they are time intensive as well, and they take away from the 95 minutes of direct therapy that I think needs to be prioritized. I think we also need to look into nursing and rehab assistance. They offer a potential opportunity to increase non-direct therapy intensity that's not measured. And we don't really fully understand or fully appreciate the impact of that at present. But that's not the data we have to work with, unfortunately. But that's an area that we're starting to look at in more detail. I do think that adjunct therapies are worth applying. And when you think about it, they're probably best applied as you hit that plateau. So, about that 3-month period, 2.5 month, 3-month period, when the patient's being discharged into outpatient therapy. Remember, I talked about specialized outpatient therapy units tend to be the ones that are most likely to apply adjunct therapies when we looked at our study. It's probably because that's where it makes the most sense, right? It's at that point where patients plateauing with your intensive therapy. Now's the time to try something different. Kind of like Stephen Page used to talk about it, like cross training. You meet your maximum in terms of your training, and then you do some cross training to try and see if you can't push it up to the next level. And the same thing here. This is probably the point at which we're best to apply adjunct therapy. It doesn't mean adjunct therapies don't work really well over here, but I just think the focus has to be on intensive therapy. Adjunct therapies are probably best applied here. However, it's important that we don't apply them over here, right? Like 8 weeks later, because they had to wait 8 weeks for their outpatient therapy. That doesn't make any sense at all, and probably is not a great use of resources. So we really need to be thinking, I think, about applying those new adjunct therapies at that point where they're plateauing. But you saw from my data, if we wait too long, we don't get the same impact. So we have to be very careful to make sure that the therapies here are applied at that point where they felt it plateaued enough they can be discharged, but we still want to try and increase the amount of improvement that they're seeing. And so that's why I'm really big on adjunct therapies at this point now. But that, the problem with applying it primarily in an outpatient setting is that if the waiting list gets out of hand, as it often does, you're looking at getting almost into the chronic phase, and you're just not going to get the same bang for your buck. And so it's not going to be as good a use of your resources. And so adjunct therapies are best applied when recovery begins to plateau. And as I mentioned before, a national survey suggested it is most likely to be applied in that setting under our current usage. And I think there's some natural things that have happened, a natural evolution that leads to that. Adjunct therapies are also responsive to time post-stroke, so you don't want to wait too long before you apply them. And you don't want those extended waiting lists in outpatient therapy. It just becomes inefficient. So this, I thought I would present to you the new data and try and put it into a modified model of stroke rehab designed to maximize recovery and maximize the use of resources. And thanks for listening.